I'm Michael Lanuti. I'm one of the thoracic surgeons at Massachusetts General Hospital in Boston, Massachusetts. Um, I'm in a rather large division of thoracic surgeons, and I'm the director of thoracic oncology for our division. I have clinical interest in lung cancer, esophageal cancer, mesothelioma, and I also have a translational lab that looks at novel treatments of lung cancer. Pulmonary function tests are a battery of tests that measure the working capacity of the lungs. And in and of itself, the test has no associated pain or risk to the patient. So who should this test be used on, particularly when in the context of lung cancer surgery? These tests can be reproducibly and objectively measure someone's lung capacity to inform the surgeon or the physician about the amount of air the lungs can hold. And that part of the test is termed spirometry. And in addition, how forcefully one can empty air from the lungs, particularly in 1 second, called forced vital capacity in 1 second, or the term that someone will see on a report is FEV1. A low forced volume of air in 1 second will limit the amount of lung that can be removed during lung surgery. The other component of pulmonary function testing is to assess the quality of gas exchange, that is oxygen and carbon dioxide, across the lung. And this part of the procedure is called diffusion capacity. This is a very important number for thoracic surgeons since it's been independently predictive of outcomes after lung surgery. That is a very low diffusion capacity, below a number that we use 40%, which we can often see in patients who have moderate to severe emphysema, would make a patient high risk for lung surgery. This type of information, as I mentioned, is very helpful for thoracic surgeons to estimate how much lung can be safely removed without crippling the patient's daily activity or subjecting the patient to the need for long-term supplemental oxygen. Outside of lung surgery, this method is often used to follow patients with asthma, chronic bronchitis, emphysema, chronic obstructive pulmonary disease, or even restrictive lung disease, and some patients might be familiar with the term pulmonary fibrosis. In patients with a history of tobacco use, there may already be a loss of some lung capacity. Pulmonary function tests are one of the measurements to see if there's enough lung reserve to tolerate lung surgery in patients with early stage lung cancer. All patients who are being considered for lung surgery, where the plan is to remove any portion of lung, should undergo pulmonary function tests. Pulmonary function tests are not necessarily needed for patients undergoing small diagnostic procedures or biopsies of the lining of the lung, known as pleural biopsy. Pulmonary function tests are administered in a outpatient setting that may take up to 15 to 20 minutes to complete. The task is done in a sitting position, and the patients are asked to breathe deeply and exhale multiple times. If patients have a difficult time with pursing their lips around a device, that might alter the test results. As I mentioned, there is no pain or risk to the patient. The other part of the test that I mentioned is diffusion capacity, where the patient has to inhale a gas called helium, or be placed in a box-like telephone booth where we can adequately measure gas exchange.